Welcome everyone to another episode of the Development and Analysis of Human Movement. Today we're going to go over the head, the neck, and the trunk. So the neck and the skull, the head is created out of two parts. One part is called the cranium and the other is the facial skeleton. The cranium, if you look to the left, is the part that is in the yellow, while the facial skeleton is in pink. The cranium's main job is to protect the brain. So you see it just kind of creates a big bowl there. The facial skeleton supports most of the organs for sight, smell, and taste, while also providing muscular attachments for mastication or chewing. The vertebral column, we've kind of discussed this before, but let's dive into it a little more. Just realized I didn't turn on the slideshow, my fault. There we go. So as I was saying, the vertebral column, you see here, vertebral wise, we have 7 cervical vertebrae. Okay, 1 and 2 have different names. Let's see if we go over that here. We don't yet, so we'll talk about it in a little bit. The axis and the atlas is what they're called, and you'll see that their shape is a little bit different as well. Then as we get down to the bottom here, you see where C7 ends, T1 begins. You see the curves kind of change at each little segment of the spinal column here. So at T1, the thoracic column goes all the way down to T12. Okay, you see there, and that is what we call a kyphotic curve. Kyphotic curve. Okay. This is a lordotic curve in the cervical spine, and then we get a lordotic curve down here at the bottom in the lumbar spine as well, as we look at L1, L2, L3, L4, and L5, and then we get to the sacrum, which we've kind of talked about before, but this is where that lumbosacral joint kind of happens right here as well. Okay. So if you're an easy way to remember how many is breakfast, lunch, and dinner: 7 o'clock, 12 o'clock, and 5 o'clock. Okay, 7 cervical, 12 thoracic, and 5 lumbar. Okay, they're arranged so that there's an anterior and posterior curve formed, which we kind of talked about a second ago. So lordotic in the cervical and the lumbar, and kyphotic in the thoracic cavity. These curves make a spinal column much stronger than if it was just straight. Think of it as a spring. It's a little bit more bouncy. It allows it to deform a little bit more and makes it about 10 times stronger than if it were just a straight line. And it's triaxial, so it can go forward, back, side to side, and it can rotate as well. Okay. So the atlas. C1 is called the atlas, and if you look at it, the cranium rests on this atlas here. So it's very flat, okay? It's named after the Greek Titan Atlas. If you think of the guy, picture of the guy holding the world on his back, that's what they're talking about here. Okay, this has no body or spinous process on it. It forms a joint between the occiput and the cranium and the atlas, and it's called the atlanto-occipital joint. It's primarily flexion and extension of the head happens at this joint. Then we have the axis. Okay, it serves as an axis of rotation for C1, and this is the atlantoaxial joint, so AA, and this is the atlanto-occipital joint. Okay, and the primary function of this is rotation of the head. It also has no body in terms of typical vertebrae. Okay, so you can see here that the atlas is very shallow. It doesn't have those typical spinous processes on there on the posterior aspect, or the transverse processes or styloid processes on the sides. It's very flat. Just really allows that cradle to, or the cranium to just kind of be cradled on this position here. Then you see this dens here on this axis. This sits right through this little hole right here. Okay, and you see it spits right through this little hole right here, and it allows more for that rotation. See, it serves as the axis of rotation for C1. So this sits on it, slides right in like a Lego, and then moves around for rotation. because of how the dens sits inside of this atlas here, it would not be very functional for flexion and extension because of the bone-on-bone connection that happens there. So then the cranium sits upon the atlas and it's maintained by a joint capsule, so a lot of ligamentous support is at the C1 and cranium. And the capsule maintains its stability through these various ligaments. And then C1 and C2, the atlas sits upon the axis, and the dens of the axis projects into the atlas, which we just discussed. And then the dens shares the opening in the atlas with the spinal cord. So a posterior translation can damage the spinal cord. So if it slid back, it could cause some damage in there. C3 through S1 all typically have the same type of articulation. A vertebrae, the vertebrae increase in size and thickness as they move distal. So if we look at our person here, let's go to systems, just because it's a little easier. So you can see, sorry, sorry. And I just also realized I'm not actually on screen. Sorry. Again. Okay. Let's take these out. Right here. And now you can kind of see, as I highlight it here, you see, let me rotate, I'm not on the right thing. Sorry guys. But you can see here, if it lets me click it, I should have just clicked something else. Oh man. Okay, so this is our atlas here. You can see how it's a very flat bone. You see the yellow and how flat it is, right? And the cranium just kind of sits on it. And you saw all those things I was clicking that it picked up. Those are all ligaments right there. Then we have the axis here. And you can see how, so look at this here. So if you're looking at the yellow, you can see the little dens here, right? And then you can see the atlas, so you can see how it goes right through there. Sorry, wrong button. Right, you see how it goes right through. And then as we move down, we start to get our typical shape of our vertebrae. Okay. Sorry guys, I just realized it probably would be easier if I just did it this way, huh? So now you can see it a little better now, right? So you can see that atlas, how it's very, very flat right here. You see that? You can kind of see there how the shape is just it's almost like a disc, right? But then you can see here in the axis how it protrudes and projects through. There we go. How it projects and protrudes through. Oh, there it is. Okay. That dens right there. And you can see that. And then you can see how, as we move a little more distal, from the head, how these start to look, and they have bodies now, right? So they all have bodies, and they just keep increasing in size as you move lower. So this would be C7 right here, and then our thoracic as it hits the rib cage there. And you see how the bodies increase in size. Okay. There's an intervertebral joint, and that's the weight-bearing portion of the vertebrae that articulates with the other vertebral bodies. Okay. And then we have what we call the facets. Okay, the facets are the posterior bilateral portion of the vertebrae that articulates with the facet superior inferior of the vertebrae. Okay, the C-spine facets are located diagonally between the sagittal and coronal plane, and it allows for an increased motion of the head and the neck. And the T-spine facets are located on the coronal plane, and they allow for increased rotation and lateral bending. So let's look here. I rotate all the way around. There. So you can see here, the facets are on the side. So you see these facets right here, how they articulate with each other. Right, so as I was saying, right, the C-spine facets are located diagonally, and they allow for increased motion of the head and the neck. So if you look at it, you can see that it's mostly what they're going to allow for is more rotation, right, because you're not going to run into these little wing facets as they get distal. You see how these are much wider here? They're going to hit things. So like this will hit the ribs, so you don't get much motion when you rotate out of your thoracic spine. Okay? And then what will happen here is this allows a little bit more flexion and extension, where these spinous processes in the back will hit each other as you move into extension. This will go down as this goes up and the head goes up. You can feel how your head kind of arches back, and these spinous processes actually hit each other, causing a bony stop or a firm end feel to create that stability. And then with anterior, with flexion, you kind of bring it to your chin. Usually your chin hits your sternum, and that's what stops it. But also these vertebrae, these facets located a little bit more anteriorly, will also stop and add some stability as these rotate forward as well. These facets will hit the one underneath them. But then as we start moving into the thoracic cavity, you see how they move lateral. And now they're wide out to the side. And that continues all the way down the spine here as you go down. You see that. So in anatomical position, the line of gravity passes through the anterior portion of the vertebral body, because that's where the majority of the weight of this bone would be, right? So while we do have all these spiny articulations in the back, most of the weight is tied up in the vertebral body. So this big round piece here. So right in the front, in this portion right there. And then in flexion, the load shifts further anterior and it compresses the discs. So I didn't mention that, which I should have, I'm sorry. But like between each one of these, you can see this little fibrocartilage right here. And these are our intervertebral discs. Okay, they're like little jelly donuts. Okay, this one shows it pretty well. You can see how it's kind of clear. And there's what they call this nucleus pulposi in the center of it, and it's surrounded by this annulus fibrosus. And if you look here, this is kind of the jelly donut, what it kind of looks like as you were to cut it open or bring it out. So what happens is in flexion, the load shifts further anterior and it compresses this disc. Okay, and it causes the space on the vertebral foramen and the intervertebral column to compress the spinal cord and nerve roots. Okay. So let me show you here. So this hole here, right here, is our foramen, and that's where the spinal cord goes through. So it runs up and down the entire spine through that space right there. You can see it right here, this space here, there, and as we continue to move down, you'd be able to see it if I moved some of these ribs out of the way. But that's where it goes, okay? And as we flex forward, right, we compress this part, which means this would create a little more space and push that nucleus propulsi back, thus creating a bulge and pressing into this space. And that's what a bulging disc does, and that's why it hurts, because it's compressing on a nerve when that happens. So then, that's kind of the bony and structural limitations of the cervical spine, as much as we're going to talk about it here in this class. But then let's get into the muscles, right? So just a reminder, this is kind of a review. We've talked about it in and out of muscular properties, and then as we talked about muscles in the upper and lower extremities. Okay, the origin is where the superior portion of the muscle typically, and it's the more stable bone of the muscle attachment. So the muscle attaches to most stable bone, which is the origin typically, and then the insertion is the mobile attachment of the muscle. So typically that's the side that's moving. So whatever the insertion is attached to, that's where it typically is going to, or what segment it's going to move. Okay, it's often the inferior portion. The muscle fibers, if you pay attention to those, if we've pointed out with like our bipinnate muscles and concurrent muscles and convergent forces, if we talked about those, if you pay attention to those muscle fibers, it'll tell you the direction of the muscle movement. Okay, contractility is the muscle's ability to contract. The extensibility is the muscle's ability to stretch. We've talked about both of those. And elasticity is the ability of the muscle to return to its normal resting place. Okay, this is just one more time talking about that kind of sliding filament theory a little bit, where we have the sarcomeres that are the small longitudinal bundles that create the larger muscle. Okay, that's right here, these little guys. Then we have actin, which is the thin filaments that compose the muscle fibers. Okay, so we see it down in here, the actin filament. And then we have the myosin, which is the thick filaments that compose the muscle fibers. And then once again, this is a review of the sliding filament theory, and that's when a motor neuron stimulates the heads of the myosin filament to reach forward and attach the actin filament and pull the actin towards the sarcomere. Okay, if you need to review that, I would, because a lot of you guys kind of missed that on the quiz, so maybe it'll be on again. Muscle, okay, these are the types of contractions, another review, just because I feel we need it. Okay, isometric muscle contractions are when the muscle produces a force, but it does not change the length. So if you put your hand under the desk or table that you're sitting watching on, and you contract your arm, and the table doesn't move, but your muscle is creating a force and you're pushing into that table, that is what we call an isometric contraction. Concentric contraction is when the muscle shortens. So if I flex my bicep and the bicep shortens, that is a concentric contraction. But then if I hold that muscle in contraction and something's pulling my arm straight, that is an eccentric muscle contraction, where my muscle is elongating while still creating a force. Then we have isokinetic muscle forces, which is where the muscle produces a concentric and eccentric contraction at the same speed and force. So typically you need a special machine for this, because it maintains the same amount of force output through the entire range of motion. And that's difficult to do with a dumbbell or any type of manual resistance. So you really need a machine to do that. So that's kind of moving away from what's being commonly practiced in physical therapy and rehabilitation settings. More often than not, you're working on isometric or isotonic contraction. Isotonic contractions are the most common contraction, and it's where a fixed force with a variable speed. So the speed will change. So as you lift that dumbbell, you may start really fast, and then you hit the weakest point of that muscle contraction, and then it slows down a little bit, and then you get back to the top of that contraction, and the speed changes. Once again, we talk about agonist, antagonist muscles. So agonist muscles are the muscles that cause motion. Antagonist muscles are the muscles that perform the opposite motion. So if this muscle, bicep, is flexing, right, that's the agonist. because it's causing the elbow flexion. But the antagonist would be my triceps surae, which, or not triceps surae, that would be my calf. My triceps, and that's the muscle that performs the opposite motion, so it's moving against the agonist. So that would, because the triceps causes elbow extension, that would be the antagonist during this chain, or during this motion. Then once again, just a review, kinetic chains, right? So closed chains are where the distal moving segment is fixed and the proximal segment moves. So if you're looking at sit to stand, my feet do not move, right? So that squat or that sit to stand, these feet are fixed, this part's moving, so that would be a closed chain. Open chain is when the distal segment moves and the top proximal segment does not move, so that would be like a knee extension. So, since we've reviewed all that, let's go into the muscles of the cervical spine. First, we have the sternocleidomastoid. Okay, there's two heads of this muscle, and if you look, it originates on the sternum and the clavicle, and it inserts on the mastoid process, which is kind of right behind your ear. So because of this kind of flips everything we just talked about, right, with origin and insertion. The origin is usually more superior, and the insertion is more distal, but you have to think of the moving segment. So as this contracts, what it's going to do is it's going to do cervical rotation, right? So because of that, the insertion is actually on this mastoid process, and it causes that rotation because that's what moves. Okay, so the moving part, like we said, is the part where they call that the insertion. Then we have the scalene muscles. These are three little muscles that attach to the vertebral bodies there on C2, C3, and C5, and they insert on the first and second ribs down here. So what they do is bilateral cervical flexion. If they do it together, if they're contracting on the same, or the left and the right scalenes, if they're all contracting, it'll do cervical flexion. But if not, it'll do lateral flexion, right? So if only one side flexes and these shorten, it's going to pull the head sideways like that, right there. You then have the splenius group, which is 10 different little muscles. We have splenius cervicis, rectus, captus, posterior, major, and minor as well. So then we have here, they originate on the occiput and insert on C7 to T3. I don't really care that you need to know these, just know they exist and know what they do. We do not have to palpate them. We're not going to palpate them in lab. Just know the splenius capitis right here kind of attaches on that occiput and goes down to the spinous processes. And then splenius cervicus kind of attaches at the transverse processes C1 and C3. And then it goes down to this spinous process of T3 to T6. Normal range of motion for the cervical spine, so we have flexion here, extension there, lateral bending there, 45, and rotation of 80 degrees. And then we move on to the trunk. So the anterior trunk muscles, that's the rectus abdominis and the obliques for the most part. They're separate. The rectus abdominis is separated by the linea alba, and it originates on the pubic crest down here, and it inserts on the xiphoid process and the costal cartilage of the 5th through the 7th ribs. The action is trunk flexion, and it compresses the abdominal contents, so the stomach and the spleen and the liver and all those. The oblique muscles here, the internal obliques are on the 8th through the 12th ribs, and they insert on the iliac crest and the inguinal ligament right down here. The bilateral trunk flexion and compression is its job, and when both sides contract bilateral, it's trunk flexion, and unilaterally it's lateral bending. Okay, so when one side contracts, it flexes the trunk to that side. Then external obliques originate at the lower 8th ribs and insert on the iliac crest and the pubic tubercle down here. And when both sides contract, we get trunk flexion, and when one side contracts, we get a lateral bending again. On the posterior aspect, you can see here, okay, we have a lot of these little spinalis cervicus, the longissimus capitis, iliocostalis cervicus, longissimus thoracis, yeah. Okay, we just call those the erector spinae muscles. Okay, because what they do is they just help keep the spine upright. You can see how they're all little attachments to all the little facets and the spinous processes on this posterior aspect. So when you are palpating along the spinous process, the muscles to the lateral and medial sides of that spinous process, that big muscle group, that's your erector spinous. Okay? But then we have your QL, your quadratus lumborum. Okay, this is on the 12th rib, and it goes to L1 to L5. So you see here how it kind of has these lateral attachments as well. And it sits on this iliac crest to the 12th rib. And what it does is it does trunk lateral flexion and hip hiking. Okay? So the anterior trunk flexors and the posterior trunk extensors work in opposition to keep us upright. Their line of pull compresses the vertebrae to increase stabilization. So as the posterior pulls down and the anterior pulls down, if you imagine this ring as the disc in the middle, it would just pull everything straight down as they both contract, thus compressing. That's why you're actually taller in the morning and shorter at night from a day's worth of disc compression as well. So the normal range of motion for trunk flexion, so that is this here. Okay, so I'm here, trunk flexion, like that. Trunk extension, going backwards. Lateral bending, 25 degrees there. And rotation. Oh man, that was sore. Painted my house yesterday. Pretty sore. 30 degrees of rotation. Some common pathologies that we just kind of want you to be aware of. Thoracic outlet syndrome, that's compression of the brachial plexus, so all the nerves as they come out of the cervical spine, and the subclavian artery and vein that run between the first rib, the clavicle, and the scalenes. So right in here, they can kind of compress, creating what's called thoracic outlet syndrome, where you get numbness and tingling because we're compressing a nerve, or you can actually get decreased blood into your arteries and veins. And you can feel that in your radial pulse. Torticollis is a deformity of the neck where the cervical spine and the cranium are laterally bent and they're rotated, so it's like this, right? A lot of times little kids will get that as they come out of the womb. Kyphosis is an increased thoracic curve, so we think of that, and that's almost like your humpbacks. Scoliosis is where you have any amount of lateral curve in the spine. Spinal stenosis is a narrowing of the vertebral canal. We then have spinal stenosis, which is a narrowing of the vertebral canal, so that hole that you saw in those vertebrae, that is what they call spinal stenosis when that narrows. Often that's from repeated trauma to a specific vertebrae, because you think of Wolff's Law and it needs to protect it. So it feels a lot more stress in that area, thus it narrows that vertebral canal, thus causing an impingement of that spinal cord, or the spinal nerves. A herniated disc, which we discussed earlier. Ankylosing spondylitis, which is a chronic inflammation of the vertebral column. It can lead to a loss of mobility over time. And then compression fractures, where you load the head axially, typically presses down, collapse of the vertebral body, typically caused by a trauma. So that's all we have today on the trunk and cranium. Okay, and take care.